Good afternoon, everybody. This is Bonnie Vandermeulen, Training Coordinator for Wisconsin Facets. On behalf of our entire Wisconsin Facets staff, I'd like to thank you for joining us today. Our webinar today is entitled Raising Awareness of Mental Health Needs in Our Schools, and our presenters today are Anna Moffett and Dan Von Baron. Anna is the Executive Director of the Dane County chapter of the National Alliance of Mental Illness, or NAMI, the nation's largest grassroots mental health organization dedicated to building better lives for the millions of Americans impacted by mental illness. Anna has previously worked as an elementary school teacher, as a member of the Madison Metropolitan School District Board of Education, and as a parent advocate with Wisconsin Family Ties, as Executive Director of NAMI Dane County. Anna's goal is to build on the strong tradition of advocacy and support for people affected by mental illness, including families whose children experience chronic and severe mental illness. Also with us today is Dan Von Baron. Dan is the Youth Program and Outreach Coordinator at NAMI Dane County. It is my sincere pleasure to introduce to you today both Anna and Dan.
Thank you, Bonnie.
Thank you, Bonnie.
All right, I just wanted to get started. First of all, just giving a little bit of historical background in regards to NAMI Dane County, or the National Alliance on Mental Illness. NAMI Dane County is actually the founding chapter. It was founded here in Madison back in 1977 by Harriet Shetler, Bev Young, and Nancy Abraham. They were all parents to adult sons who were living with schizophrenia. And so they really led the charge in transforming how individuals living with serious mental illness, SMI, were receiving treatment within the community. Originally, the group's name was the Alliance for the Mentally Ill, or AMI, which means French in friend. But after several years, they became a national organization. So that's a bit about the organization. And again, we support individuals and their loved ones who are impacted by mental illness through education, advocacy, and support. And thank you for having us. Here you go, Dan.
Yes, hello again, everybody. Again, Dan Von Baron. Happy to be here. Some striking data and some statistics on mental illness, kind of specific to young adults and youth. As we can see, young adults aged 18 to 25 years have the highest prevalence of mental illness. That's 25% roughly. 16.5% of youth in the US aged 6 to 17 have experienced a mental health disorder, and this is done in 2016, equating to 7.7 million of us. 1 in 6 US youth aged 6 to 17 experience a mental health disorder each year. 50% of all lifetime mental illness begins at age 14. So this is striking at how early it can really start. 50.6% of US youth aged 6 to 17 with a mental health disorder received treatment in 2016. That is a lot of young people. High school students with significant symptoms of depression are more than twice as likely to drop out as compared to their peers. And 31% of high school students report feeling sad almost every day for 2 or more weeks. So these figures kind of certainly illustrate to us the extreme need to increase our awareness in our schools. You can go ahead and do the next one. Yeah, thank you. Just to kind of review or introduce some fundamentals of mental illness. Well, it is a health condition that affects a person's thinking, feeling, and behavior, often on a daily basis, often in episodes, and then they feel better for a while, and then it comes back. May affect someone's ability to relate to others and function in their daily life. It affects everyone differently, and even with people with the same diagnosis won't necessarily exhibit the same signs and symptoms. There's a lot of co-occurring things that can go on at the same time. Yeah, mental illness can be influenced by genetic and environmental factors. But the good news is, if there is some, it's very common and often very treatable. And really one of our goals at NAMI National and Miami-Dade County is to really kind of end the stigma and get young people to talking about this. So diagnoses, the Diagnostic and Statistical Manual of Mental Disorders is what's often used. It's a handbook used by healthcare professionals to diagnose mental disorders. It contains descriptions, symptoms, and other criteria for diagnoses. You can go ahead and thanks, Anna.
Great, thanks, Dan. So this is just some more data that's specifically related to youth in our high schools, and it kind of breaks out what are the biggest pressures. Obviously, academic is very high. I would guess that more students are identifying it now that we're in the pandemic and everything is being done virtually, has probably increased that number. Appearance, social status, and then involvement or belonging, connectedness to the community. The other big thing on the slide that I just would point out is the impact that social media is having on youth. And what we can see with the 450 youth aged 11 to 17, 97% of the participants indicated that they use social media. So that's a huge number of youth that are using social media. And again, what we're seeing is there an increase in different platforms that they can utilize. Of that group, some of the impact that we saw: poor sleepers, 47% were classed as anxious. And then if we look at the other side, we can see that a large number have experienced cyberbullying, and then also people are feeling more excluded when they're viewing stuff on social media. What we also know is there's been a steady increase in the number of children and youth that are identifying as being depressed, anxious, or having other mental health issues. And so it's just to remind people to really be mindful about how frequently your children or the students are using social media, and really being aware of what they're using. Again, the 1 in 6 that Dan mentioned earlier is the number of, this is actually for ages 2 through 8 that will experience a mental health condition. Today, we're going to be going over these different mental health conditions. There's going to be a lot of information, but you will have the PowerPoint, so you can go back and read it and revisit that information. So don't feel like you're going to get overwhelmed. You'll have this to review on your own. So kind of starting off, we'll start off talking a little bit about anxiety disorders. What's interesting about anxiety disorders are these are the most prevalent type of mental health conditions. So one in 3 of adolescents, so that's 13 through 18, will experience an anxiety disorder. So really just generally the emotional side is, feeling overwhelmed, being apprehensive. It could be really feeling tense or jumpy, almost like your body is always on a high alert, tracking what's going on. But another emotional symptom is irritability and restlessness. And so a lot of times you could find students that are experiencing an anxiety disorder might be acting out, kind of behaving aggressively in a setting, and it could be directly tied to their anxiety. Kind of the physical aspects, obviously shortness of breath, heart, sweating. A lot of times kids will identify as being tired, not being able to sleep. And then we also see a large number of children, especially younger children, who will talk about having an upset stomach. And so those are really the somatic symptoms that we see tied to anxiety disorders. The 2 types that will go in, there are others, there's a range, but the big ones that we see are generalized anxiety disorder in children and youth. And that's really just when children or youth have excessive worrying about even everyday things. And so we're not clinicians. I want to be clear about that, but we both have lived experience. And so throughout the presentation, I'll talk a bit about myself and my children. And so, you know, really what I see is a lot of going to the doctor is extremely difficult for my daughter, and she will hyperventilate if she thinks she needs to get a shot. So that's, you know, where she has a fear. I think for my son, he has a lot of fears around germs and that type of stuff. Another big anxiety disorder is social anxiety. So it's not shyness. It's really an intense fear that children and youth can't control about having to interact with other people. With that, about 90% of children who have selective mutism, so where they're unable to talk, also have an underlying anxiety disorder. So those might be the students who, when the teacher calls on them in class, they're just not able to talk. So I think if we have educators, I think getting to know your students and definitely being able to provide different outlets for children and youth to communicate if you feel like there might be a social anxiety component for a student. I think a lot of times too, these are students that are either afraid to leave the classroom because they don't want to miss anything and get called out when they come back. And it's also too a case where we see anxiety disorders having a really high correlation to truancy. So it's one of the leading causes of truancy for high school students. Oh. And now I'm just going to share a quick clip of a high school student sharing about their experience.
When I was in 8th grade, I started to get very worked up about everything needing to be perfect, keeping my grades perfect, having everyone perceive me in a certain way, and not allowing myself to make mistakes. And that continued on through high school. And eventually I found out that it was anxiety. I think that the hardest part about dealing with it, that was the most tiring, was that my brain couldn't agree, that I had half of me saying, you can't mess up on this test, you need to do it perfectly. And then the other half of me was like, no, you don't, you'll be fine if it's not great. And that it was just my two parts just fighting with each other about what was right. And that was really exhausting to live with. After I started to notice that something was wrong, I told my primary care doctor during a physical, and she asked me a couple more questions and then was able to determine that I needed more support. So then I started going to therapy. And therapy is something that I would really highly recommend if that's something that you have access to. And even if you don't have access through your doctor, you can try to find it through your school or through your community. For me personally, it's just really nice to have someone who has like no stake in your life, doesn't know you personally, just to be able to hear your problems and know that they're not going to judge you or think less of you because you only see them for an hour every month or every 2 weeks. And I think that was just something that was really nice for me. And it felt safer than talking to my parents because I was very worried about like, stressing them out. So high school is hard and it has taken a toll on my mental health, but I've also gotten a lot better at using coping skills, knowing where my limits are, and just knowing how to take better care of myself. So high school has been a journey, but I have gotten a lot stronger at not letting my mental health, my mental illnesses run me. When I've dealt with all of my mental illnesses, I've always kind of felt really alone, like this was my brain's issue and that I didn't want to involve anyone else in it. But I've learned how to talk to my parents, talk to my friends, talk to my therapist, and really get help and just tell people how I feel. And I've gotten a lot better getting open about that. And a reason that I do a lot of the advocacy work that I do around mental health is to make sure that no one else feels like they have to hold all of their feelings inside of them, and that they know that any stigma that they feel is not necessary, and that they can talk to someone, and it's okay. And it's okay to not be okay.
kind of nice to inject a little hope into all of this. I thought that did a good job of that. And building on that a little bit, did you know that as many as 80% of teens suffering from depression can be successfully treated if they seek help from a doctor or therapist? So it just goes to show that what is stated in that video is demonstrated and documented success. And some of you may be doing that important work now, and some of you might be supporting somebody who's going through it, but there is hope. We're going to talk next about specific depressive disorders. To kind of just define two of them here. A major depressive disorder is a common and serious illness that negatively affects how an individual feels, resulting in a persistent feeling of sadness, and that just is kind of ever present. And during that time, and then a persistent depressive disorder, or dysthymia, a depressed mood that lasts for at least 2 years. A person with persistent depressive disorder may have episodes of major depression, along with periods of less severe symptoms, but symptoms must last for 2 years to be considered persistent depressive disorder. And so some symptoms are kind of flushed out. Really, on the right side there, you'll see a feeling of extreme sadness and a kind of depressed mood that's ever present, a loss of interest or pleasure in activities that were once enjoyed. Might see some changes in appetite or weight, changes in sleep patterns, sleeping far too little or sleeping way too much, a loss of energy or increased fatigue, an increase in purposeful physical activity, a lot of hand wringing or pacing, slowed movements in speech that is observable by others that is different than it used to be. Feelings of worthlessness or guilt, difficulty thinking and concentrating or making decisions, and then sadly, often thoughts of death or suicide.
And
Another
Dan,
one that kind of,
oh, sorry, Dan.
please
Well, I was
go.
just going to offer too that I think with all of these symptoms, people have to be mindful that, especially in adolescence, there will be mood changes and mood swings. And so really, when you're assessing whether someone might be struggling with depression, it's really how long it's lasting. If someone's going into a depression for 2 to 3 weeks, that would be a concern.
Absolutely. And then the other one is bipolar disorder, and a brain and behavior disorder characterized by severe shifts in a person's mood and energy, making it difficult for the person to function. It often causes repeated mood swings that can often make a person feel high or manic or very low or depressive. Some of the mania symptoms exhibit as increased energy, very poor concentration, an abuse of drugs or other substances, racing thoughts, fast talking, extreme irritability, and a heightened sense of importance. That's kind of on the mania side. And then when you see it in its opposite, you kind of see that decreased energy and fatigue, distinct loss of interest or pleasure in activities, extraordinary amounts of difficulty concentrating or remembering, making decisions, thoughts of self-harm, and an often sad, anxious, or empty feeling mood. So when you look at type 1 and type 2, the type 1 is a person who experienced one or more episodes of mania. And type 2 is classified as a person who has experienced depressive episodes shifting back and forth with hypomanic episodes, but never a full manic episode. So they do kind of classify bipolar in two different ways. Thanks, Anna.
Thanks, Dan. The next disorder that we want to provide a little information around is around obsessive compulsive disorder, or OCD, and then some other related disorders. So for obsessive compulsive disorder, it's really comprised of the obsessions, which are intrusive or irrational thoughts that occur repeatedly. Sometimes children and youth may be aware that they're irrational, but might be other times where they actually believe the thoughts are rational. And so with obsessive compulsive disorder, really when you're talking about it, you need to be mindful that you can validate their feelings without actually agreeing that that's what's happening in reality. So the obsessions are the thoughts, and so common obsessions, of course, there's contamination. And I know for a lot of youth right now, we've seen an increase in youth that are concerned about contamination because of the COVID-19 pandemic. So really being afraid of touching anything, having people around them. For some, leaving the house is impossible because they're so concerned about contamination. Also, losing control or harm obsessions are also something that occurs, and these can be probably the hardest for people to deal with, because there's actually an obsession where people have the thought that they are going to hurt somebody or yell at somebody or attempt to kill somebody. And so these are very, very obviously very concerning for the individuals that are experiencing this. And then there's also perfectionist obsessions. We're just trying to make sure everything is perfect, not being able, I see this with students where students aren't able to complete work because if they make one mistake, then they absolutely cannot move beyond that. It gets thrown away and they have to start over. And so they're stuck in that obsession. Compulsions are the other component of this disorder. And these are really the repetitive acts that provide the person experiencing the obsessions some relief from the stress and anxiety of the obsessive thinking. So again, tying back to contamination, you're going to see children and youth really overly focused on washing or cleaning things. I know in my household, a big thing is my son is very concerned about germs, and so he will only use a glass once and then it gets put away. Or if he's going to use silverware, the first thing he's going to do is look at it and check on it. So those are kind of some of the things that he utilizes to, reduce that anxiety. Checking on things, making sure things are okay. Checking in, with parents too, that really going in and asking, is anybody hurt? What happened? This you might find too for younger kids. It's that whole, you need to check under the bed. You need to check in the closet to make sure nobody's there, to make sure it's safe. So if you do it once, that's pretty typical. But if you see like a child checking, 5-10 times over and over to make sure things are safe, that would be concerning. Repetitive actions, so just deciding what is going to be the set number of times you might do something, and until you can do it that many times, tap your finger, say a word, you can't move on. And then also there are mental compulsions, and those are really like thoughts that are in your head, kind of the what if questions. So for someone who might be dealing with obsessions around harming others, it would be going through with thoughts, okay, what if I did hit that person? What if I did go to jail? What if I did have to leave my house? So really the compulsion is the thinking about the obsession. There's also body dysmorphic disorder. So that's just an obsession with your physical appearance. And it's not like vanity and trying to look nice, because it can consume hours of your day, which is not really like getting up and trying to just look nice. I think this is another area because of the use of social media and so many pictures and Snapchat, that we're increasingly seeing more children and youth struggling with this type of disorder. There's also excoriation, and that's really, it's a repetitive bodily function disorder. So you're really picking off your skin. So you might pick at scabs on your skin. You might pick at your fingernails to the point that they're, chewed way down, or picking off the skin on your cuticles. So those are common ways that this manifests. And again, this is done to relieve anxiety and stress for the individual. And people may not even be aware that they're doing it. There's also something called trichotillomania, and that's the act of pulling out hair. Typically, it will happen at the crown of your head, but in youth and children and youth that I've seen, I've also seen eyelashes as an indicator, as well as eyebrows. And so not like shaping your eyebrows, but really picking them out until they're all out. So these are some common obsessive compulsive disorders. The other type of disorders that I want to talk a little bit about are eating disorders. And again, this is more common than folks think. The one thing I wanted to point out is that out of all mental health disorders, eating disorders have the most individuals die. So that's something that doesn't get talked about very much. So it's very serious if you're starting to see your child or youth or students presenting some of these manifestations. So the first one is anorexia nervosa, which we hear a lot about. And again, what you'll see emotional symptoms is like fear of eating in public or eating with other folks, irritability, social withdrawal, lack of mood or emotion. Also, too, a lot of times what we'll see is an obsession with food and exercise. And so I can speak personally to this. In high school, I did struggle with this. So for me, if I were going to consume food, I knew I immediately had to go out and exercise, run 2 miles. Then I would eat, then I would run 2 miles. And so it was very disruptive to the point of I wasn't able to attend school because I was caught in the cycle. So physical symptoms with that, obviously loss of menstruation, constipation, irregular heartbeat, low blood pressure, dehydration, and insomnia. Another disorder is bulimia nervosa. And so this is where an individual eats a huge amount of food, a large amount of food, they have the binge, and then they use other means to get rid of it. So they can do that through vomiting, laxatives, or again, that excessive exercise. And so with bulimia, we do see a lot of people get caught in a cycle of feeling a lot of shame and guilt because they're feeling like they can't control this behavior. And again, to some of the physical symptoms, long-term, there's a lot of damage to teeth, acid reflux, there can be cardiac arrhythmias and heart failures. The other eating disorder that we don't talk as much about is a binge eating disorder. And so this is actually the most common eating disorder there is. And so what binge eating disorder is really just where you're eating very large amounts of food, but you are not purging or getting rid of that. And so again, similar to bulimia, there's a lot of people can feel a lot of shame, disgusted with themselves, depressed. And then obviously on the physical side, you'll start to see, and weight gain is something that could be common with this. It's not all the time, but dry skin, brittle hair, acne, high blood pressure, and low energy. And so the good news is with binge eating disorder, although it's the most prevalent, it's also the most treatable.
And moving on, thanks, Anna, to post-traumatic stress disorders, or PTSD. These, as most of us know, are a mental health condition triggered by often a specific traumatic event or series of events, both kind of experienced and witnessed, so it can be either or. Symptoms, and I've worked with many folks with PTSD over the years, may start right away, or it may not manifest for years and years. Some real kind of foundational things are the intrusive memories that occur, the recurrent, unwanted, distressing memories of the traumatic event. Sometimes nightmares will be very common. Severe emotional distress or visual reactions to reminders of the traumatic events. And just as an aside, what I've noticed with people who have gone through events such as these is that it's often so many times where they try to start something new, a goal in their life, or begin a trajectory, and they undermine them. They're undermined by these memories and all the stress and stuff that goes along with it. And so it can be very, 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 very difficult for someone to manage. So often they engage in a high level of avoidance. So, avoiding thinking about it or talking about the event. Some may take it as far as avoiding places that resemble where the event may have even looked, or certainly the place where it happened. Activities or people that remind you of an event is something you'll avoid. One might avoid. Negative changes in thinking or mood that almost kind of, run the risk of becoming permanent, or negative thoughts about self, others, or the world change and become negative and can manifest in memory problems and the lack of interest in activities that were once enjoyed. Some changes that one might see in someone's physical self or emotional self will be just how easily startled or frightened someone might be, always being on a high level of guard for danger, having contingency plans kind of laid out way ahead of time and sometimes verbalized, irritability, angry outbursts, and overwhelming guilt or shame. So when it's so important to come from a trauma-informed place when trying to assist folks with PTSD, because trauma is what their core issue is. Other things, we're going to kind of move on to neurodevelopmental disorders. They're associated primarily with the functioning of the neurological system in the brain and have an early onset, typically during the developmental stage. For some examples here might include autism, and dyslexia, and hearing and vision loss. Can cause difficulties with speech and language, motor skills, behavior, memory, and the brain's ability to learn. Symptoms and behaviors of children with neurodevelopmental disorders often change as they get older. And the one that we talk about most, at least that I've run into my work with young people over the years, has certainly been attention deficit and hyperactivity disorder, or ADHD, characterized by inattention, hyperactivity, and impulsivity. The inattention is just a real quick ability to be distracted and bored very quickly. Trouble completing assignments, not paying attention when spoken to, might have an affect of daydreaming, difficulty processing information at all, or certainly with speed, and struggling to follow directions, mostly because they stop listening perhaps halfway through. Hyperactivity is another, accompanying it with fidgeting and trouble sitting still, frequent talking, touching, playing with everything around them, and their impulsivity is affected. So their affect will appear often impatient, sometimes acting without regard to consequences, difficulty waiting or taking turns, and a propensity to interrupt others.
Thanks, Dan. So that was more specific information. So just generally speaking, when we're talking about what are some warning signs of mental illness, what are things that we all can be paying attention to or looking or checking in with? So if your child or the students, you're seeing a dramatic change in mood, so really extreme sadness, withdrawal, that would be concerning. And again, kind of going back to what I said before, you're looking for changes in mood that take place over an extended period of time. So, you know, everyone's going to have a good day, bad day, okay day. But if you're seeing somebody stuck in a pattern of being down and depressed or withdrawn, then that would be that would be a warning sign. Intense emotions, and again, this includes angry outbursts. For some folks, their mental illness may actually manifest itself into challenging behaviors. Changes in behavior. So obviously sleeping too much, skipping, going out with people, secluding yourself in your room or the house. And then again, if you notice that they're not enjoying things that they used to participate in, being aware of that. Also an increase in risk-taking behavior. Again, we see that this, and some of this will go along with adolescence. We do know that there's a greater desire to engage in risk-taking behavior just because of brain development. But really seeing if there's a pattern of that, checking in with them and checking in with them to see how they're feeling. Difficulty concentrating, decreased performance in school, self-injury or self-harm is a very big indicator. So if you see a student engaging in cutting or burning, to check in with them, that's a strong indicator that there's an underlying mental health condition. And then again, self-neglect, you know, just if all of a sudden your child is no longer taking a shower, if they're no longer putting on clean clothes, I mean, this would be an indicator that something might be going on. And then of course, if children or youth or students are actually sharing that they're having suicidal thoughts, they have plans, or there's been an attempt, that would be an indicator as well. So just moving on to briefly touch on suicide. I want to begin by saying there is a myth out there that if you talk to children and youth about suicide, whether they're experiencing suicidal ideation, that there will be a greater risk that they will attempt, and that is not true. It's actually the opposite. By talking about it with children and youth, you decrease the likelihood of an attempt being made. So it's really important as adults, educators, caregivers, that you think about how you might talk to a child or youth. And I think in our experience, it's good to be explicit. So simply going out and asking, are you thinking about killing yourself? And really being clear and, you know, moving through that conversation so that you can really assess the level of risk. You know, asking about how specific is the plan, if they have a plan, how lethal is it? And then also, do they have access to the means that they're talking about? Because that would all guide you to what would be the next steps that you would need to do for that child or youth. So what are some warning signs? Obviously, talking about it, not saying they have no reason to live, saying that nobody loves them, saying that they're a burden, that feeling of hopelessness. You might see an increase in alcohol and drug use, aggressive behavior, withdrawal from friends and family, mood swings or reckless or impulsive behavior. Also, to another warning sign to be on the lookout for is if you have someone that has been in a very depressed state, feeling hopeless, but then all of a sudden they're almost in a state of elation. I would really go out and ask, because that can sometimes be once somebody has a plan, then they just feel elated because they know that the pain will end. And I think that's the big thing with suicide is people complete suicide because they're trying to escape the emotional pain that they're experiencing. Behaviors that you might see, collecting or saving pills, securing a weapon. Another thing you might see is someone giving away things, especially things that are important to them. Making plans, if you're talking about an adult, you know, really checking into their finances, and then saying goodbye to family and friends. So if you are concerned about somebody, there is the Hope. You can text Hope Line to 741-741. And then there's also the National Suicide Prevention Line, which is 1-800-273-8255. And I think for time, I'm going to skip this one. So, Dan, are you good to go?
Sure, of course. It's just, again, I want to kind of focus on the good things we know that do work in the prevention of suicide, because it's just so important to take exorbitantly seriously, because it's the 10th leading cause of death. So, to talk about some components of prevention for suicide, do not overlook any behavior changes. Suicide does not discriminate. At-risk individuals for suicide can be of any gender, any age, and any ethnicity. First thing to do is to not ignore your instincts on this. Identify if you feel it. It's probably true. It's worth asking. It's worth delving a little bit more into. So identify and support at-risk individuals. Be attentive and ask friends if they're okay when you begin to notice changes in their behavior. Asking an at-risk person if they have a plan, removing available lethal items can help keep them safe. Be there. Listen and learn about what the individual is thinking and feeling. Now, research shows us that acknowledging and talking about their feelings can decrease their suicidal thoughts in that moment. Help them connect with a trusted individual if it's not you. Don't say, oh, great, you're going to go talk to that person. That's good news. Kind of follow through if they will allow you to. Save the National Suicide Prevention Lifelines number in their phone, as well as local crisis hotlines. And then follow up with them. Stay connected. Staying in touch after a crisis can make a huge difference. Show them that you still care and are there to support them. Studies have shown that the number of suicide deaths go down when someone follows up with the person after a crisis. Very important. Some of the barriers that people who are feeling this way to care are the stigma of self-harm and or mental health, the navigating of our very large mental health system, taking into account insurance and what they will and what they won't pay for. And it's getting to therapy, getting to a doctor, to a psychiatrist. So that transportation piece can be very difficult. Throughout their time, if they're not able to manage their job and they're missing lots of work and hours, or if they have to take disability, their dollars go down. So then they're concerned about housing and food goes up. And then really kind of considering where they are at geographically. Are they rural and urban? And obviously the resources you've taken into account, their effectiveness and their availability compared to where we live.
Great. And one other thing too, I would add to this barrier. So one silver lining of the pandemic is that we really have expanded access to telehealth. And so we have found a lot more people engaging in therapy because it does eliminate some of these barriers. It does eliminate the stigma because, you know, it can be difficult, especially for youth, to walk into a clinic and be identified. Transportation has been a huge barrier as well. So if you can just get your therapy right from home, it works much better, especially if you have concerns around childcare. I think the one thing we found out too is it's really pushed us to have better broadband access, because in our rural communities, people don't have access to that, and so it's been limiting. But I know at the state level, we're looking at making changes so that there is better access.
great.
So just what are some strategies to support yourself or somebody else? Some big areas in the treatment, we have therapy or talk therapy. So there's a variety of different therapies that you can have access to. There's cognitive behavioral therapy or CBT, and that really helps individuals recognize and change the problematic patterns of their thinking and behaving. And this has been found to be very successful with children and youth experiencing depression, anxiety, obsessive compulsive disorder, and post-traumatic stress disorder. There's also dialectical behavioral therapy or DBT. And this therapy really helps individuals regulate their intense emotions and improve their interpersonal relationships through validation, acceptance, and behavior change. And so this therapy is used frequently for individuals living with borderline personality disorder, living with suicidal ideation, as well as self-harm. Another therapy is art therapy. But in the past few years, this therapy has really expanded tremendously. So there's horse therapy. We see peer support and group therapy has been very well accepted and has shown good results. And I know at Miami-Dade County, we're very excited to pilot youth support groups in our schools so that youth can come together and learn from each other. So, and many times medication is a part. So really, you know, therapy, there's typically the talk therapy tied together with some medication, although not all people utilize medication. It's different for everybody. Just generally, healthy coping skills are just a list here. Obviously, self-care. So really making sure you're sleeping, you're getting good food, you're getting exercise. That's important. And some other strategies are journaling, meditation, painting, drawing. I think it's important to stay connected, especially during COVID, finding new and different ways to spend time with family and friends. So, you know, setting up those Google meetings or doing FaceTime so that you can still stay connected even when we're having to physically distance. So those are a few that I think are good to do. I think unfortunately, you know, we just have to be mindful that there are negative coping skills. And so really to be aware of that as an educator or parent, if you're seeing those skills come up, to really acknowledge that and see if they need help. And then these are resources that are specific to Dane County. But you can see there is, well, that's our crisis line here in Dane County. But again, the suicide prevention line is 1-800-273-8255. So you can reach out to that. I would say also, if you're ever looking for resources in your area, we have affiliates all across the state. So even going over to NAMI Wisconsin, to their website, you can find out if there is an affiliate in your region. Here in Dane County, we have a support line. So that's 608-249-7188. So folks can always call that and we can direct you to other organizations as well. And obviously, Wisconsin Facets is a tremendous resource. Wisconsin Family Ties, Disability Rights Wisconsin, WISPE would all be places where there would be additional information as well. And I believe that's the last slide. So I did want to leave some time to see if anybody had any questions for us that we could take.
Sure, can you hear me?
Yep, I can hear you.
Okay, great. I do have a couple of questions for both of you. The first one is, what is the best way to provide professionals who work with children who have mental health challenges with the information that they would need to be able to help them, let's say teachers in schools, for example? How do you get that information to the school population?
So I think one great way, again, is I'm going to just say reach out to your NAMI affiliate, because we have programming similar to this that we do for schools that give information, like a background around mental health, and then again, looking at different treatment options and different community supports. That is called Ending the Silence, and that's for middle and high school. And then we also have something for elementary school called Mental Health Chat, which is really bringing that conversation to a younger level. So I would say, reach out to an affiliate and talk to school staff. And here in Dane County, we have a pretty robust behavioral health programs within our schools. And so even reaching out to local school districts to see what they have available. Dan, did you want to add anything?
Sure. If the question was pertaining to specifically how to get clients or students information from a therapist to specific school personnel, one way to do it is to just call a meeting where you have your therapist and say guidance counselor there with parents' permission and with hopefully students' permission to take what is coming out of there and have it work so that the professionals in the school can best apply it to their either their trauma-informed approach or their formal 504 IEP.
Okay, I have another question that just came in here, and it says, do you have experience with DM-ID2? It is a mental diagnosis manual with accommodations for kids and adults with ID.
I am not familiar with that. No. But I think that work is expanding because there is such a high rate of co-occurrence between mental health disorders and like developmental disabilities. I wouldn't be surprised, as well as with intellectual disabilities. I am not familiar with the manual.
Okay, thank you. And then another question for you. How much do the both of you believe should be shared with the teachers and school personnel about a child's mental health challenges?
Well, I mean, I think, so you're kind of talking about how much parents should share?
Yeah, I think that's what the person who's asking the question is interested in knowing. Do you lay it all out there? Do you tell about all the challenges, or is there some reason to hold back some stuff? In other words, how can we best inform teachers about how your child to present in the classroom?
Sure. So, I mean, I would begin by saying, that would be a conversation, especially with adolescents, that you'd want to talk with the child or youth to get their feedback of how much they want to have shared with school staff. So really talking with your child about what they feel comfortable having shared. I encourage parents to share the information that they're comfortable with. So, but that doesn't mean you have to get way, way, way down into specific details. But I think it is important, even just having like a one pager, saying, here are some things that you might see my child, display when they're at school. Here are some things that will help work through that. Here are some things that are not going to help. Like, I think that is information that is really important for school staff to have, especially when you're talking about mental health challenges, because they can manifest in ways that can really be misperceived by staff. So really having that honest conversation, but with permission of your child or youth.
I would completely concur.
One of the people who are listening has mentioned the fact that they felt pretty strongly about wanting to know how a child might present in their classroom, and the special ed teacher was really reticent to provide any information on the child's IEP, for example, because they didn't feel that was appropriate. So how can you approach the situation and say, But, you know, in order for us to provide the best environment for this child, we need to have some information.
I don't think there's anything that would, I guess I would say the staff could try to have a conversation with the family directly if it's not, if the case manager isn't wanting to disclose information. If it's school staff, I would believe that they would have access. If it's like a teacher, you should have access to a student's IEP.
Okay,
I
and
guess
then
it depends on who it is. I don't think like but like a PE teacher should have access to that. They should be part of the team planning.
I agree, but if there is hesitancy, one could speak conceptually about what someone's exhibiting kind of in a direction, and then provide, and the special ed teacher might be able to suggest, without providing too much detail, some tools that might work to help redirect them in class or keep them engaged, or again, to inform them of trauma and or other that doesn't have to be specific.
Okay, thank you both. One last question relates around telehealth, and you know, the comments before we're talking about the enhancement of telehealth in general. What is your specific feelings as it relates to telehealth versus in-person therapies? I guess the person understands that, you know, like transportation and some of those things are issues, but if you had a choice, would you make that choice?
You know, I think what's interesting is there was some data that came out of Milwaukee where there really were a large number of people that either felt it was the same or it was better than in person. I mean, I think the cons to telehealth is that obviously you lose a lot of those body cues, right? How somebody is holding themselves and some of the facial stuff. So I think that, and then also too, a big con is that you might have people who, you know, we have a lot of folks who will not utilize the internet. There's tremendous anxiety. So I think it really depends on specific individuals. I think the benefits, again, is you get rid of some of those barriers like childcare, transportation. And you also, too, it does open up the door to more culturally responsive services because you could actually be working with providers that may not be in your geographical location.
Okay, well, thank you both. That's the end of our questions right now. Do either of you or both of you have a closing comment you'd like to make?
I would just say thank you for having us. And like I said, folks can reach out to us if they're looking for some support or ideas at namidanecounty.org.
Okay, thank you
Thank
both.
you all for your time.
Yeah, thank you both very much. I'm sure that all who participated today learned a lot from the webinar. I know that I did for sure. This concludes our webinar. We'd like to thank both Anna and Dan for their presentations today. Please be reminded that Wisconsin Facets has over close to 100 now scheduled webinars and trainings for the year 2021. And please check out our website and register for any of the upcoming trainings for the remainder of 2020. And please watch for the short evaluation that will be coming your way after today's live presentation. Again, thank you, Anna and Dan, and thank you everybody for participating today.